Good morning, my dear students. Today we are going to learn about examination of the hand. And again, this video is for medical students who are awaiting their first clinical appointment, and this is like an introduction to the examination of the hand. There will be two more videos. The second one for the medical students who are doing their second clinical appointment, and the third one for the medical students who are doing their professorial clinical appointments. When it comes to the examination of the hand, again it includes history, examination, and then analysis of the history and examination findings. The history that you are going to take is depend on the presenting complaint of the patient. So I am here mainly concentrating on your examination of the hand. So there are few basic principles that you must remember when it comes to examination of the hand. The hand is belong to dual organs. So you must examine both and you must compare with each other. And again, you have to follow the principle of sequence of examination. That means first inspection, then palpation, then if necessary percussion, if necessary auscultation, and finally special tests. Examination of the hand also begin with inspection. In inspection, you have to inspect not only the hand with complaint, but also the other hand and also both forearms, both arms up to the shoulder joint. So you must expose both upper limbs up to the shoulder joint and inspect both anterior, posterior and medial and lateral aspects of hand, forearm and arm. So what are the things that you are going to look? You are going to look for the features like surgical scars, the injury or trauma marks, the lumps, features of inflammation. Rarely you may see swelling or distended veins, or sometimes the features of lymphadenitis or thrombophlebitis, or you may see features of muscle atrophy, especially the thinner and hyperthinner areas. And you may notice guttering in intermetacarpal spaces, which is more prominent on dorsal aspects than the palm aspect. So other features include the deformities. So deformities of the hand are primarily of the fingers, and those include mallet finger, botanier deformity, swan neck deformity, or you may see more complex deformities if the patient is having especially rheumatoid arthritis for a long duration. So it's likely that all small joints are deformed in such patients. And another important thing that you may notice is the burn marks in the finger tips. And I would like to speak a little further on surgical scars. So there are specific surgical scars which are designated to the hand, and it's better if you can remember those, but there are few surgical incisions which you must remember as medical students. One would be incision for carpal tunnel, and you must know the common sites for ganglions, where you may see surgical scars for previous ganglion excisions. So commonly dorsal surface of the wrist, second commonest is ventral surface of the wrist, and third one is area close to the distal interphalangeal joints. And another important feature that you may check on your inspection is features suggestive of trigger finger. You may see the fingers in flexed, fixed positions, or you may see features of ulnar claw or complete claw, and you may see features of deputant contractures. So those are the other things that you may notice in inspection. So after inspection, we will move into palpation. So then again you have to palpate the hand primarily for warmth, which is unlikely to be seen in possible cases that can be given to the medical students. But always you can palpate thin and hyperthin areas mainly, and also other joint areas for tenderness. And then you have to palpate certain specific areas looking for few common possible pathologies. One is DQA variant tenosynovitis, where you have to palpate the first dorsal compartment of the wrist, which include extensor hallucis longus and abductor hallucis brevis tendons. So you palpate over them to exclude possible tenderness which suggestive of DQA variant tenosynovitis. And then you may palpate over the area where we get A1 pulley to detect early features of trigger finger, which may be tenderness or a nodule. So if you can't really remember the location of A1 pulley, you may palpate over the metacarpopharyngeal joint area. After palpation, you have to assess the neurology of the hand. So first you do the sensory assessment, which include both touch and pain. When you are assessing for sensory defects, but you have to remember two common possible findings. One is Glauben-Stocking type, the other one is nerve-based sensory loss. So in Glauben-Stocking type of sensory loss, there is a sensory loss all over the hand until you reach a certain level. In nerve-based sensory loss, you have to target three main nerves of the hand, but you must remember about the palmar cutaneous branch of the median nerve. Reason is that branch travels over the flexor geniculum, and that is paired in carpal tunnel syndrome. So the points that you are going to check sensation will be the area of the thinner eminence, which is supplied by the palmar cutaneous branch of the median nerve, and sensation over the thumb and index finger, and then the sensation over the little finger and the ulnar half of the ring finger. So index and thumb for the median nerve distribution, little finger and ring finger for the ulnar nerve distribution. And then you check the sensation over the snuff box for the radial nerve distribution. So after sensory assessment, you have to move into the motor assessment. When you are doing the motor assessment, your main worry is to check for median nerve, then ulnar nerve, and then for the radial nerve. But you must check all possible actions of the hand. For the median nerve, the ideal test would be pen test, where you assess abductor pollicis brevis, which have nerve supply from the median nerve. So there are two more thinner muscles and the abductor pollicis. Out of these muscles, abductor pollicis has dual nerve supply from both median and ulnar nerve, and both flexor and opponent pollicis is notorious in their nerve supply. But it's good if we can assess the function of all four muscles. Then we are going to check for other small muscles of the hand. Mainly we are concentrating on abduction and adduction of fingers that reflect the ulnar nerve function of the hand. And then you concentrate on the radial nerve, where you are going to check the extension function of the fingers. So in that way, you can complete the motor function of the hand, but there are few special tests that you need to remember for motor function of the hand. So another sign that we know as pointing index is a feature of median nerve weakness or injury. And again, there are another two special ways where you can quickly check the three nerves of the hand. One way is stone for median nerve, paper for radial nerve, scissor for ulnar nerve. Other ways, we call it OK sign for median nerve, victory sign for ulnar nerve, thumbs up sign for radial nerve. So these are the two ways of assessing three nerves of the hand in a quick way. After the motor assessment of the hand, then we have to move into the special tests of the hand. So those are mainly Tinel test or Tinel sign and the Pallen test. Those are the basic tests which all medical students should know. But you must remember there are many more specific tests in relation to the hand which are beyond the scope of this video. So in this way we finish the examination of the hand for beginners, and after watching this video you can search for second video on hand examination. Thank you.